Okay, well, I think I will start and then people can join us as they're entering the room. I want to welcome everybody. Thank you for joining us. My name is Pam, and I'm going to be the moderator for this session. Just to make sure you're in the right place, we are here for the session called Pediatric Thyroid Cancer Session 1. What tumor genetics tells us and doesn't tell us, and how it relates to the patient, as well as we'll be talking about when should families worry about an inheritable risk for developing thyroid cancer. So we're lucky enough to have two doctors present to us for this session. Just a little housekeeping item. If you have any questions, we will take those. We'll try to answer all of the questions that we can. I am very excited and pleased to introduce both of our doctors who will be presenting today. The first is Dr. Amy Franco. She is an assistant professor and investigator with the Center for Childhood Cancer Research at the Children's Hospital of Philadelphia in Philadelphia, Pennsylvania. Dr. Franco directs the newly established Pediatric Thyroid Cancer Translational Research Laboratory. She earned her PhD in cancer biology from Vanderbilt University, Nashville, Tennessee, and conducted her postdoctoral fellowship in genetics of thyroid cancer at Memorial Sloan Kettering Cancer Center, New York, New York. Her research interests include the molecular biology and genetics of thyroid cancer and improving quality of life and survivorship outcomes for thyroid cancer. Dr. Franco is a recipient of a ThyCa Thyroid Cancer Research Grant and has spoken at many ThyCa conferences. She'll be speaking first. Second, we're going to have Dr. Jonathan Wasserman. He is a pediatric endocrinologist and associate professor at the Hospital for Sick Children in Toronto, Ontario, Canada. He also serves as a project investigator of genetics and genome biology at the Research Institute. Dr. Wasserman's research focuses primarily on pediatric thyroid cancer and spans both clinical and translational domains. His research includes genetics and genomics of pediatric papillary thyroid cancer, healthcare utilization patterns among young patients with thyroid cancer at diagnosis and during follow-up, and identification of prediction models to improve assessment of thyroid nodules in children and to gauge malignant potential. He received his training at Harvard Medical School and the Massachusetts Institute of Technology, and subsequently pursued an internship and residency in pediatrics at Children's Hospital in Boston. He previously earned a PhD and completed postdoctoral training in genetics at the University of Cambridge, England. Dr. Wasserman serves as co-chair of the American Thyroid Association Pediatric Thyroid Cancer Guidelines. So welcome both of you. I'm so excited to have both of you here to present for us. And I know Dr. Franco, you'll be starting us off.
Well, thank you so much, Pam, for that really generous introduction. A few housekeeping rules for me for this perspective is that this talk is for all of you. This is not my talk. I know this stuff at this point, and I really want to make sure that I'm hitting on the points that are really of interest to all of you and make it relevant. So please make sure to stop me. And if you have questions throughout, or there's something that I've presented that doesn't make sense or you don't understand, please stop me. I want to make sure that everyone's able to follow along and really kind of go through this journey with us. And like I said, it really is for you. And to make sure that it's relevant for all of you. So I'm delighted to talk a little bit. This is really the focus of my laboratory is really trying to understand the genetics and the molecular biology of thyroid cancer, and to better understand the differences between adult thyroid cancer and pediatric thyroid cancer. So myself being a thyroid cancer survivor, having been diagnosed at 23, I was right on that cusp, and I still have so many questions that remain unanswered about my own diagnosis and tumor, and hope that the work that we do in the lab and continuing the work, working with patients and advocacy, that we can continue to unravel the mystery, I think, of thyroid cancer. So the first thing that I wanted to start with is just to kind of make sure that we're all on the same page with some of the the nomenclature and the terms that we talk about with talking about the genetics of thyroid cancer. And really the most important thing to understand is the difference between what we call germline versus somatic. So germline and this germline mutations are really going to be a lot of what Dr. Wasserman is going to be talking about after me. And this is what we refer to oftentimes when we're talking about genetic counseling and testing to find out whether we have risk factors for thyroid cancer or for any other type of cancer. So germline mutations are detected and they're passed to every cell in the body. So every single cell has that mutation if it's germline. We know that these are mutations that are inherited within families. So they're passed between a mother and or a father onto their children. They occur during development. So sometimes we're really, really unlucky and we get a germline mutation or inherit a germline mutation very, very early during development and embryogenesis. And in that case, maybe it wasn't passed on from a mother or father. The big key to realize, though, is that this is just really cruddy luck. This is no one's fault. Even though we talk about being passed from a mother or father and it's in the family, it really still is about dumb luck. There's nothing that we can do really to change our DNA. This is just, the cards that we were dealt. But it's really important to understand this difference between the germline and somatic. And further with the germline, like I said, it occurs during the development of the embryo. So it's something that happens very, very early before we even know often that, before we know that we're carrying a child. And again, it's found in all cells of the body. It's passed on and it affects every cell in the body. So this is also something that's important to know is that these mutations and in the germline, in and of themselves don't usually cause the cancer or the disease to happen. They do something and they are kind of lowering the threshold so that something can happen later on. And it's really important to understand this because these germline mutations are in every cell, but can increase our risk for thyroid cancer, even though these mutations and these changes are found in every cell, not just within the thyroid. So in contrast, and what I'm going to talk about during most of my talk are what we call somatic mutations. And these are the mutations that we find that are only associated with the tumor itself. So they're only found in certain cells. They're known to be, as we call them, acquired, which means it happens after development. It happens at some point. We don't always know what causes these mutations. It can be exposure to radiation, but there's a lot of things. Your body is constantly making DNA all of the time. Every time a cell divides, every time you grow, you have it has the opportunity to introduce these mutations. But when we talk about tumor mutations or somatic mutations, it's only within the tumor or the organ in which something's gone wrong. It occurs in regular cells. Again, it's after the development. So it happens later in life. This is not something that happens in utero or during very early development. Again, happens anytime. It's found only in that organ or tissue that has the cancer. It's not something that we pass along. So if we have a mutation within our thyroid, and only in our thyroid, we don't have the ability to pass that mutation, just like we actually will not pass that mutation to other cells in our body. It's only going to stay in thyroid cells. And it really only affects those cells locally or within the specific organ near the tumor. So this really just kind of summarizes exactly what I talked about, that the somatic and the germline mutations, they're very interrelated and important, but they are separate, and that these germline mutations usually in and of themselves aren't causing the disease itself, but it's lowering the threshold and making us at risk for potentially acquiring more somatic mutations or those differences in our DNA, specifically in the thyroid in our case, and that's what leads to the tumor. And again, like these somatic mutations, they haven't been there forever usually, and they're not in every cell of the body. So now with kind of understanding the difference between these two different types of mutations, I'm gonna introduce this, and I know it's really complicated and I don't want everyone to get really bogged down. This is your biology and chemistry and biochemistry 101 for the day. But the thing that's really important to understand is that the mutations and the things that go wrong in cancer are actually really critical components of what makes a thyroid normal as well. So these mutations and these pathways, that's what all of these circles and dots and arrows, these are all completely normal. And you can see over in the left-hand side where the TSH receptor, a TSHR, this is what we know, TSH. This is what stimulates the thyroid to produce thyroid hormone. We absolutely need it. The problem is when it becomes mutated and it's always on, that's when we run into problems. And that's why we develop cancer with these different mutations oftentimes, is because these pathways that are critical for the thyroid to function normally, when there's a mutation, they can't turn off. And it's when they're in hyperdrive and it's like a car without the brakes and they can't stop, is when it slowly pushes the thyroid to stop functioning as a normal thyroid and it gets pushed to this cancer state. So it's really important to understand these aren't mutations and unique type of things to the thyroid. The problem is the fact that these pathways no longer turn off like they're supposed to. So it's really important, and I think critical to understand that all of these pathways and all of these processes that are happening are absolutely critical for the body. So we can't just stop these pathways. We need this for normal function too. We need to better understand why they go wrong and how we can try to fix it specifically in the tumor. So I know this is going to be really, really complicated, and I don't want to overwhelm you. I'm just showing it because I want to tell you that in adult thyroid cancer and in adult patients, we know a lot about what goes wrong. And there's been a lot of really important studies that have shown that, again, all of these pathways that we know are really important for the normal thyroid, they go wrong in thyroid cancer. And we've defined them in the adult, but what really was interesting to me and what has driven me into this field is that we know pediatric patients and adult patients, the tumors react differently, and thyroid cancer looks different between adult and pediatrics. And we wanted to understand whether they have the same pathways that are going wrong and the same mutations that are occurring, or is there something unique to pediatric cancer and pediatric thyroid cancers? And the reality is that make a long story short, is that actually a lot of the mutations look really similar. In pediatric patients, in this first box that I've boxed in on the right, I know it's going to be difficult to see, it's really complicated, but the big story to get out of this is that in these pediatric patients, most of them have what we call a fusion oncogene. And I'm sure many of you have heard this as your children have gone through diagnosis, or maybe you haven't, but that many pediatric thyroid cancers are driven by these fusion oncogenes. It's when two genes, for some reason, get stuck together and they don't function the way they're supposed to. This is different than what we see, and this is still a somatic mutation. This is still something that only happens in a thyroid cell, whereas this is different than what we call a point mutation, which happens, a lot of you may have heard of BRAF mutations or RAS mutations. That's when a piece of the DNA, and the DNA is an alphabet, A, T, C, and G. And when one of those letters is misplaced or the wrong letter is put in, that's when you get a mutation, and the gene or the protein, these pathways, they don't act the way they're supposed to. They don't shut off. And in pediatric patients, we see that many of their tumors have these fusions. The two genes join together and don't function the way they're supposed to. Whereas in adults, it's most often that they develop these mutations where there's just one letter that gets wrong and inserted incorrectly, and that's what leads to the tumor. So what it tells us is now we understand that the biology is a little different and the genetics driving these tumors are a little different, but it doesn't give the whole picture. And what I wanted to show with this is looking at what your risks may be, and the association of whether you have a BRAF mutation versus these fusion genes. And what this graph is trying to show you with the little dot, it kind of shows what your risk is, and the arrows above it and below it show kind of the error associated with that. But at the end of the day, what's important to understand is what we've been able to show in other groups is that patients that tend to have these fusion genes, the two genes that get stuck together and function in the wrong way, have an increased risk of having lymph node metastasis and even sometimes distant metastasis. And these are the patients that often don't have remission, that are most in need of having RAI, and a lot of times will have persistent disease that remains in the lymph nodes. But what's really important is that this is an association and this is a risk. This doesn't mean just because you have a fusion that this is the type of cancer or the problems that you might have. And I think this is something that's really important. This is about what does genetics tell us and what does it not tell us? It tells us something about the risks, but it doesn't always tell us exactly what is going to happen. And so this is just another way, again, trying to compare what we know between pediatric cancers and adult thyroid cancers. And these bars just represent the percent of patients. And I'm just going to draw your attention to the last two bars on the right in each of these graphs, in which you can see BRAF on the bottom versus RET NTRK, that's the fusion. And what we found is that the patients in our pediatric patients have bigger, really dark blue and medium dark blue lines in the fusions, as you can see at that very last bar on the right-hand side in the first panel. These patients have the most risk for spread and distant spread with lymph nodes, whereas in adults, we really don't see that same type of spread. So it's telling us that these mutations are acting differently between our pediatric and our adult patients. And I think it's starting to tell us it's really important for us to start to better understand what these mutations can predict and maybe be associated with in pediatric patients compared to adult patients. And what we've as parents have always known is that our kids are not just little mini adults. There's a lot of other things that are different about them. And this is starting to show us that even the cancers that they develop, as well as these very same mutations being in both pediatric and adult, act very differently. And finally, this is just a bar graph. This is some of our own data that we have here at CHOP, as well as actually some of the data Dr. Wasserman has from his group in Canada and a bunch of other groups across the country, is looking at which of these tumors and in these different groups have RAS mutations or BRAF, these point mutations where the DNA and that code is wrong, versus having these fusions where two genes get joined together. And the blue bar represents the adult patients. So you can see most of the adult patients have these BRAF mutations and these point mutations, whereas all of the other bars, the orange, the gray, and that yellow bar, all represent different pediatric cohorts. So groups of pediatric patients from those that were exposed to radiation, those from groups besides us at CHOP, and then that yellow bar at CHOP. But really what you can tell is that the fusions are much, much more prevalent, and we see a lot more fusions in pediatric patients than we do in the adult patients. So these gene mutations, it's really important for us to start to detect these genetics. And I think here at CHOP, we actually do genotyping We look at what genes have gone wrong or where these mutations are in almost all of our pediatric thyroid cancer patients that come through, so that we can try to better understand some of the risks that may be associated with the mutation they have. That we know these fusions seem to have a higher risk for having lymph node metastasis. So in the future, we hope that being able to use some of this information before a patient goes into surgery, that maybe this can help guide us on just how much surgery is going to be necessary to make sure we remove all of the tumor, as well as potentially lymph nodes that may have it, have disease in them. And we're now understanding that this is very different than what we see with our adult patients, where in the adult world, it's the BRAF mutations that we get really nervous about for our adult patients. And we know that they are the ones that have the most risk for recurrence. So it is really important, I think, moving forward for us to start to understand what some of these mutations are going to be within these tumors. The other thing, though, that we're really behind on right now, I think, in the pediatric space is trying to use this as a way to try to diagnose thyroid cancer. So many of you may have heard about using some of these genetic tests to look at FNA when we're trying to diagnose and trying to understand which suspicious nodules, when you find a nodule in the thyroid, may be cancer versus those that won't be cancer. We're not quite there yet with our pediatric patients. We're getting close, but we still need more information to really understand whether that's going to really help us tell which are going to be tumors and which are just going to be benign nodules. So we really need to start understanding or continue to better understand the role of each of these types of mutations, and why do kids tend to have these genes that like to get together and form the wrong thing versus having just these single point mutations where the DNA has one letter that's incorrect. We still don't know why. One thing, though, that this information is beneficial is many of these mutations now, as we do a lot more in the laboratory, we found out that we actually have very specific drugs for them. So some of you may have heard about using BRAF specific inhibitors. We can now use a drug that will specifically attack the cells that have those specific mutations. We now actually also have drugs that specifically attack some of those fusions, like RET fusions and these NTRK fusions. So it starts to tell us a little bit about what drugs we might be able to use in treatment, but it doesn't guarantee and tell us whether the treatment will work or not. So we're still getting there. It's not that just by having a tumor genotype that we magically have the magic recipes for what we're going to be able to do in the clinic and how to cure. Like I talked about, we haven't gotten there yet with our pediatric setting to really use this yet to diagnose thyroid cancer. We need to better explore and understand whether we can detect these mutations and really predict which thyroid nodules are going to be truly cancer versus those that are nodules, and we really should just sit and wait. And, to get to the point where we are in some of our adult thyroid cancers, where can we start to better understand that certain mutations really are going to be tumors we could maybe sit and wait and watch versus having complete thyroidectomies and being aggressive with our treatments. So that's something that we still need to figure out and move forward with a little bit more in the pediatric space. And I think one really important thing to understand, and this is something that I struggle with a lot in the lab, is that our endocrinologists are the ones that are treating thyroid cancer, but oncologists are really the ones that treat the mutations. So it's really critical when we start to look at some of these therapies that are specific to a mutation or to some of these fusions, that we have a really good team involved, because a lot of these drugs are not your normal drugs that are prescribed over the counter, and it really really requires this multidisciplinary team approach for us to be really precise with some of these new therapies. So it's really important when we start to treat and think about treating these tumors based on mutation that we bring a team in and really understand this and have all of the experts involved. So I do think that the future is really bright. We're very fortunate that thyroid cancer in children is still a rare disease. Fortunate because I'm so glad that we don't have as many children being diagnosed, but it makes it more difficult for people like me in our job in trying to understand how we can use this knowledge and really improve the field as fast as possible. Because fortunately, we just don't get enough samples. And we don't want to be making conclusions on just a couple of samples or a couple of tumors. We really need to make big studies, which is why we've really moved forward with a lot of collaboration. And actually, we work with Dr. Wasserman's group in Canada, and we actually have, hopefully many of you saw last year, we've formed a consortium of many of the pediatric centers around the country so that we can really take advantage of all of our expertise and put it together to try to move things forward and improve the care that we can deliver to our pediatric patients a lot faster. Because time is of the essence. And, I lived this firsthand as a young adult, and now as a parent myself, there's nothing more terrifying than hearing the word cancer. And we need to move this forward as fast as we can so that we can really preserve quality of life and hopefully improve quality of life for all of our children that, unfortunately, if they've had thyroid cancer, are really going to have to live with this the rest of their life and the consequences of it. So I just want to thank all of you for joining me and being here. I really want to thank the Thyroid Center at CHOP. I've been there now for 2 years, led by Dr. Andy Bauer, and it's really been a great place to work. My lab itself and Dr. Giulio Riccardi-Filo actually is the one who led many of the studies that I showed you. Of course, ThyCa, because they helped to fund a lot of this, but most importantly to the patients and to all of you and your generosity and your children's generosity of walking this journey with us and being partners in this, because this is the only way that we really will be able to improve outcomes and improve the quality of life long-term for all of our patients as we move forward. So with that, and maybe we have a couple minutes for Q&A, or I can also just turn it over to Dr. Wasserman and we can have some questions if there is time at the end, if there's nothing now.
Okay. There's just one question, Dr. Franco, if you want to answer it.
Mm-hmm.
What age does the thyroid cancer start to form and or grow? I know you can't find it right away or catch it early, even if you try to, but what age does it normally start in children?
So that's a great question. And it's actually something we don't know yet. And this is something that my group and what we've been very interested in is trying to understand. And one of the things, because it's just too complicated to go through some of it, but one of those slides that I showed where we looked at the fusions versus those mutations, and when the genes go wrong, the letters go wrong, or when you get two genes that go together, it seems that the fusions occur when children are diagnosed younger than 10. And it seems that maybe the thyroid changes around the age of 10. That's something that we're actively trying to figure out. This is one of the things, and this is my own bias, but I really think we need to understand a lot more about the normal thyroid before we can understand or figure out everything that's going on in cancer. And I think there's still a lot of questions and a lot of things about the normal thyroid and the normal growing thyroid in a child and during development, because the thyroid isn't completely done growing when you're born. So trying to understand what some of those changes are, I think will help us better understand when exactly a tumor can form. It can form at any time during childhood. The really bad luck of getting a mutation can happen at any time. But I think we're still trying to figure out is, are children more at risk for developing those mutations and having something go wrong at different times during childhood? And like I said, we're still trying to figure that out. And how does that equate or translate to what happens during adolescence, early adult, and then when we get to being old adults.
Okay. Thank you very much. Maybe we'll wait for the other questions until the end and have Dr. Wasserman present the slides.
Thanks very much, Pam, and thank you, Dr. Franco, for a great talk, which I enjoyed, and thanks to everyone who's here. Give me 1 second, and I'm going to share my screen. Is that looking okay?
Yeah, looks great.
All right, thanks. So thanks to Pam and to Gary and to the rest of ThyCa for inviting me to be part of this. This is the second year I've been had the pleasure of being part of the ThyCa meeting, and I've really enjoyed it and really enjoyed hearing the other talks, but also meeting many of those that are in the audience. So Gary asked me to talk about when should families worry about a heritable risk for developing thyroid cancer, and I saw one of the questions that hopefully I'm going to answer for you in the next half hour or so addresses this. But this is, as far as I'm concerned, this is another way of saying, are my family members at increased risk for developing thyroid cancer? So who am I? As Pam said, I'm a pediatric endocrinologist at Sick Kids in Toronto, and I care for a large population of children diagnosed with thyroid cancer. I also care for children who have an inherited cancer predisposition. So I run a cancer genetics clinic for patients with hereditary conditions, including thyroid cancer, but other cancers as well. I collaborate with Dr. Franco and Dr. Bauer, who I saw is in the audience today, and with whom I'll be talking a little bit later. And I, in my spare time, I coach some unruly 7 and 10-year-olds in ice hockey, and one of them is standing behind me right now, off screen. So we'll start off with a story, and this is Stephanie's story. It's as you can see on the bottom, it's a true story, but the names have been changed to protect the innocent. So Stephanie is a 13-year-old girl who was treated for a 1.1 centimeter, so fairly small, what we call a low-risk follicular variant papillary thyroid carcinoma. And she identified this, or she thought something was looking a little abnormal when she was taking some pictures. She was extending her neck and looking up at her camera and taking a selfie for her Instagram page. She subsequently underwent an uncomplicated surgical resection. She had a total thyroidectomy. And at the present time, we're a couple of years down the road, and she has no detectable evidence of disease. So her blood tests and her ultrasounds look reassuring. And at one of her follow-up visits, her father, Danny, asks whether or not he or his other kids should have any testing, because, you know, he has a few friends where cancer runs in the family, and he wants to do what he can to look out for his other kids and himself. And this is a question that comes up frequently. So I'm going to go over some terminology, and some of this may be a little bit redundant with what Dr. Franco covered right at the beginning of her talk, hopefully presented a little bit differently. And I'm going to talk about variants. This is a term used to refer to a change in the DNA code or in the genes of a cell. It's a synonym of mutation, although I prefer the term variant. It just means that there's a change. So variants can cause cancer, as Dr. Franco talked about, but similarly, variants cause red hair or a birthmark. And so I think it's a more positive term to refer to it. And not all variants are bad. Not all mutations are bad. And as Dr. Franco talked about, there's one category of somatic variants where a child is conceived from sperm and egg, and some changes or variants are acquired either in utero as a fetus or after birth, and they affect a small number of cells in the body, whether that be here on the chest or in the thyroid or elsewhere. And these individuals who are affected by somatic variants produce normal sperm and eggs that don't carry that variant. So this is not passed, the somatic variants are not passed on to offspring. So another way of calling these, rather than somatic variants, are acquired variants. They're acquired during an individual's lifetime. The converse, and what I'm going to be focusing on for the majority of the next half hour or so, are the inherited variants, also what Dr. Franco referred to as germline. So this is shown here in orange. In this case, the egg that gave rise to the individual carries this variant. And so the individual, the fetus, as well as the grown person carries that change in every cell of their body. And then they have the possibility of passing that on to their children. So 50% of the children will inherit that variant. So these are somatic and these are inherited. I don't know if you can see my cursor. So now I'm going to use the laser pointer. So when we're talking about inherited disease or germline variants, we're thinking about why does it matter? How does this affect an individual? And there are a few reasons. The first is, does this offer us the ability to intervene? If we know that someone inherits a cancer predisposing gene, is there something we can do about it? And sometimes there is, and this is the concept of primary prevention. When we know that someone has a cancer risk gene, can we prevent disease before it happens? And this is Angelina Jolie, and as many of you know, she's been very public with it. She carries an inherited breast cancer gene, and she underwent a preventative, a prophylactic mastectomy, meaning that she had her breasts removed prior to cancer developing, and that prevented cancer from happening because of her genetic risk. And we'll talk about other primary prevention as relates to thyroid in a few slides. Similarly, we know that if some individuals have an inherited risk for cardiovascular, for heart disease, then having them institute a low-fat diet, aerobic exercise, they can reduce that risk. That's another example of primary prevention. We can also think about something called secondary prevention, which means we may not, even if we know that someone has inherited a gene, we may not be able to stop the disease from developing. But we can anticipate that. And this is something that we implement quite a bit in my clinic. We undergo what's called tumor surveillance. So early disease detection allows us to treat a condition, in our case, a tumor or a cancer, when it's small before it is spread, before it causes problems to the individual. One example of this is families where there's a high risk of colon cancer can undergo early and frequent colonoscopy screening, so that if the tumors develop, which we can't prevent happening, they can be detected early and prevent them from developing into metastatic or widespread disease. In addition to the ability to intervene, knowing about inherited disease does allow individuals some insight into their future risks, even if those risks are not modifiable. For some people, such as those with Huntington disease, they choose to undergo testing for the condition because it helps them put their life into perspective, and they know what to expect, even though they don't know whether they can make any changes to that. And finally, some inherited conditions are associated with something called a syndrome, which is an association with other medical conditions. So in my kids' view, syndrome is a character from the Incredibles movies, but more commonly in medicine, a syndrome is a group of symptoms which consistently occur together, or it's a condition characterized by a set of associated symptoms or diagnoses. One example of this is trisomy 21 or Down syndrome, which is associated very commonly with distinctive facial features, short stature, and structural heart disease. So recognizing these distinctive facial features in a child allows us to recommend or to refer them for echocardiograms so we can identify whether they have other treatable conditions. And syndromes most often result from a change in a single gene or a single chromosome. So as I said, with the Down syndrome, recognition of one component of a syndrome can help us identify other components and or the underlying cause. So I'm going to move now from the background, and please feel free, if you do have questions while we're going on, to put them in the Q&A, and I'm more than happy to pause in the middle to answer those questions. We're going to move on from the background to thyroid carcinoma, and we're going to focus, this is sort of a breakdown of different kinds of thyroid cancers. I'm going to focus really on this column here, infrequently in children, but as one of the components of thyroid carcinoma is a kind called medullary thyroid carcinoma. The most common in children is differentiated thyroid carcinoma, which comprises two groups, one papillary, which is probably about 90% of children with thyroid carcinoma, and Amy talked about follicular thyroid carcinoma. And very rarely in children are forms called poorly differentiated or anaplastic thyroid carcinoma. This is a picture of a thyroid gland sitting on top of the trachea or the windpipe. And when we look under a microscope, it looks like these pools of circles or follicles. And there are two main types of cells in the thyroid gland: the green cells here, which are called the follicular cells, and these produce thyroid hormone, which is the main product of the thyroid gland, and they produce something called thyroglobulin, which are blood tests that we often will run in patients who've been treated for thyroid carcinoma or for differentiated thyroid carcinoma. In between the follicles, in between the green cells, are the blue cells. These are called the parafollicular cells that produce calcitonin. And these cells, when they go awry, give rise to medullary thyroid carcinoma. Medullary thyroid carcinoma is derived from a particular type of cell in the embryo called the neural crest cell. And these medullary thyroid carcinomas are very frequently associated with gene alterations, variants in a gene called RET. And the specific RET gene alteration, and these are different types of alterations than Dr. Franco talked about, which are gene fusions, they confer different risks for the age at which MTC develops if the RET gene change is inherited. And we talk about three different categories. There's the highest risk RET gene variants, high risk RET gene variants, and moderate risk gene variants. And the different variants confer different risks for when thyroid cancer or medullary thyroid cancer might develop. The green cells, again, are the follicular cells. These are derived from a different type of cell in the fetus, in the embryo. These make thyroglobulin and thyroxine, or thyroid hormone. And when these go awry, they give rise to differentiated thyroid carcinoma. So just getting back for a second to medullary thyroid carcinoma, in children, 95% of it is associated with a syndrome called MEN2. In adults, only about 25% is associated with MEN2, and the rest is that sporadic or somatic mutations that Dr. Franco talked about in her presentation. MEN2, also known as multiple endocrine neoplasia type 2, is a syndrome. It's comprised of medullary thyroid carcinoma, but also individuals who inherit these RET gene variants or inherit MEN2 have risks for a tumor of the adrenal glands called pheochromocytoma, and they may or may not be at risk for hyperparathyroidism or other physical features that are typical of MEN2. And those that are affected by MEN2 have a 50% chance of passing that on to their children. So it's highly heritable. So let's go back to Stephanie's story. She's a 13-year-old girl with papillary thyroid carcinoma. So that's different than the medullary that I was just talking about. She had no evidence of disease after her initial treatment, and her dad wants to know about any screening for his kids. We talked to Danny a little bit more and review their family history. There are no other family members that had any tumors, no other family members with learning challenges or autism, and you'll see in a couple of slides why I bring this up. No one else has autoimmune thyroid disease or a multinodular goiter. In other words, beyond her papillary thyroid carcinoma, there are no medical details that contribute to our concern. And Danny's still looking for the answer to his question. So one way to answer this was proposed by this group in this paper that was published by colleagues in Utah about getting close on 8 years ago now. And they looked through a large cancer registry, which is a record of all individuals affected by cancer in the state of Utah. And they started by identifying everyone who was diagnosed with papillary thyroid carcinoma. And then they said, of those individuals, how many of their family members have papillary thyroid carcinoma? Is it likely to run in their family? And then they compared that to starting with people who did not have papillary thyroid carcinoma. And what they found was that first-degree relatives were 5.4 times more likely to be diagnosed with papillary thyroid carcinoma, siblings 6.8 times, parents 4 times, and children 4.9 times. So it seemed like there was an increased risk if you were related to someone with papillary thyroid carcinoma. I'm going to go over some of the terminology here. So here's our index patient. This is Stephanie, who was treated for thyroid carcinoma. She's the index patient. When we talk about first degree relatives, we're talking about her parents, her brothers and sisters, her siblings, and if she had any children, they would also be considered first degree relatives. Second degree relatives would be her grandparents, aunts, and uncles. And third degree relatives will be cousins and great grandparents. So in this study, second and third degree relatives had a higher likelihood, and spouses did not have any increased risk. So this at face value would suggest that family members are at increased risk. This is the data from that study. And just to show you where they got these numbers, we'll look at siblings. Out of all of the individuals that they started with that had papillary thyroid carcinoma, 8,200 did not have any relatives with papillary thyroid carcinoma, but 126 did. And so putting that together, 1.5% of siblings developed papillary thyroid carcinoma. And when we start with their controls, or those that did not have papillary thyroid carcinoma, 85 of the siblings developed papillary thyroid carcinoma, and then 37,000 did not. So 0.22% of the siblings without PTC developed it. So if you divide this over this, it's a 6.8 times risk. This is what's called a relative risk, but I think what we need to think about is putting this into perspective. When we think about this risk, we see that 1.5% risk that a sibling of an individual with PTC will develop PTC. Conversely, that means that 98.5% of siblings of someone diagnosed with papillary thyroid carcinoma will not develop papillary thyroid carcinoma. So this is the absolute risk. And we compare that to 99.8% risk that a sibling of someone unaffected by papillary thyroid carcinoma will not develop PTC. So these are pretty close together, and the incremental risk of developing PTC if you have a sibling with PTC is quite small. So could papillary thyroid carcinoma run in an individual family? The answer to this is occasionally. When we think about all individuals who are diagnosed with thyroid carcinoma, 95% of them, those in blue, it happens just by chance. It's sporadic. Whereas 5% have some sort of an inherited component. When we then break out that 5%, of those, somewhere between 3 and 9% have thyroid carcinoma associated with a syndrome, whereas the remainder have what we call non-syndromic. This is FN, familial non-medullary thyroid carcinoma. So it excludes those patients with MEN that we talked about earlier. So when we talk about the gray slice here, the syndromic thyroid carcinoma, some examples are highlighted here. Cowden syndrome, also called P10 hamartoma tumor syndrome now, familial adenomatous polyposis, Gardner's syndrome, Carney's complex, and Dicer-1 syndrome. I'm going to skip through this fairly quickly because I want to allow time. I see there's at least one question in the Q&A. So Cowden syndrome, or P10 hamartoma tumor syndrome, confers us about a 5% risk of thyroid carcinoma by age 10. And by in the lifetime of an individual affected by this condition, there's a 35% lifetime risk of thyroid carcinoma. And Dr. Bauer's group, as well as colleagues in Boston over the past year, have really contributed significantly to our understanding of this risk in childhood. In addition, about 75% of people with P10 syndrome, however, have single or multiple benign nodules. So the likelihood is if one looks for some changes in the thyroid gland, we will see them, but the relative risk of cancer is still reasonably low. There's an even distribution of papillary and follicular carcinomas in individuals, which is much higher rate of follicular carcinomas than in the general population. And affected individuals may also have a large head circumference, challenges with learning or autism spectrum, and they may be at risk for other tumors. So again, when we talked about at the beginning why it's helpful to identify syndromes, If we recognize an individual with a P10 tumor syndrome, it helps us start surveillance for other conditions. Dicer-1 is another syndrome that puts individuals at higher risk for multiple different tumor types. And these individuals also develop a multinodular goiter. This is just an illustration showing the many different tumor types that affected individuals may experience. FAP is a condition characterized by frequent polyps of the colon or the large intestine, and such individuals may develop a very specific form of thyroid cancer called the cribriform morular variant. And then Carney complex is shown here. There's a slightly increased risk of developing thyroid cancer, as well as a number of other manifestations that are shown here. So red flags, and this is probably a more important slide than the previous one, are when do we think about syndromic thyroid cancer? Well, for individuals that have learning disabilities and or autism, multinodular goiter or large head. I apologize for my dogs in the background. Those that have multiple colon polyps or colon cancer, and individuals with facial freckling out of context for their family. These are individuals that may benefit from evaluation or assessment by a geneticist. The 95% of individuals who have herited thyroid cancer, which still is only 5% of all thyroid cancers, have what we call non-syndromic thyroid cancer. And these are this is sort of an alphabet soup of the different conditions or different gene changes that have been associated with non-syndromic thyroid cancer. And there's quite a large number. So here's another example of a patient I was asked to see, and the referral only said, please see this 16-year-old girl. Mom was treated for thyroid cancer and is worried about her daughter, which is certainly a reasonable concern. And this is where we started from with the referral. This is her mom shown here. The filled circles mean someone who's affected by thyroid cancer. And this young lady at age 16 was not. This means alive and well. But on further questioning, mom had 2 siblings who had developed thyroid cancer in their 40s, and they had actually died as a result of their disease, which is very uncommon, as you probably know. This individual had 2 children that were affected by thyroid cancer, as well as a grandmother. And there was no other history of other cancers in the family. So this met the definition of non-syndromic thyroid carcinoma. It raises the question of how do we define familial? Because if we go back to this, having one related relative may not increase our risk for thyroid carcinoma, but certainly a family with multiple affected members does raise our concern. As many of you know, thyroid cancer is among the most common cancer diagnoses worldwide these days. In women, it's second only to breast cancer. And so there's a high rate of truly sporadic papillary thyroid cancer. So it's not statistically unreasonable that someone with thyroid cancer will be related to at least one other person in their family who's been treated for thyroid cancer. If you were only to consider those 2 relatives with papillary thyroid cancer, there's about a 60 to 70% risk that this is going to be sporadic disease just by chance. However, when there are 3 first-degree relatives affected, and remember that siblings, parents, and children, the chances are very high that these are truly familial conditions. So what about surveillance? What do we do for Stephanie's brothers and sisters and her father? It's actually a complicated question because surveillance, meaning having them come for ultrasounds frequently or physical examination, has pluses and minuses. There are certainly potential benefits to undergoing pre-symptomatic surveillance. In some situations, there's a thought that there's a reduction in complications. If we detect disease early, there's reduced incidence of spread to the lymph nodes and the lungs, and increased disease-free survival. And many people feel that they have improved peace of mind by undergoing pre-symptomatic surveillance. They're taking control of the situation. The downsides of surveillance or the potential risks include increased anxiety or distress. Many of my patients in my cancer genetics clinic tell me that for the few weeks before their next imaging, they get very worried, very distressed about whether anything will show up. There's certainly costs to the individuals, missed work, missed school, sometimes travel to appointments that are far away. Ultrasound is not a perfect test, neither is a physical examination, and there's the risk of finding things, what we call false positives, and that's true of biopsies as well, if we do see something on the ultrasound. So getting worked up about something that turns out to be nothing. In some situations, patients may undergo surgery based on these false positives, which turns out to be for benign disease, and some would argue that that would have been, in retrospect, unnecessary surgery. And we know in children, complications of surgery are more frequent than in adults. So we do need to exercise caution when thinking about sending someone for surveillance and not doing it universally. It's difficult once we do an ultrasound to unsee a nodule, even if that nodule doesn't have any suspicious findings. Ultrasounds are an imperfect tool and they are operator dependent. The absolute risk of cancer is often low, even if the relative risk is increased, as I talked about with that study from Utah. But there is some evidence for better outcomes if cancer is detected early by screening. The evidence is not consistent. Similarly, the harms of the potential harms are poorly described. So should Danny schedule ultrasounds for DJ and Michelle? And this is the answer. Is it really, in my perspective, is a conversation with a parent and with the family, letting them know about the different risks and benefits and having shared decision-making, whether or not to proceed with surveillance. I do think that prior to initiating surveillance, we need to consider the absolute risk of there being a cancer. So for Danny's other children, we talked about there being a 98% chance that they will not develop thyroid cancer. We also need to know who's doing the surveillance. What is their clinical volume? Do they see a lot of children with thyroid cancer? Do the radiologists do a lot of ultrasounds? There are findings that are unique in children that an adult radiologist may not be ready for. And similarly, what's the skill level or the experience level of the surgeons? Most importantly, what's the mindset of the patient and the family? We want to make sure that they're fully informed. So we do need to apply caution when initiating surveillance, particularly because childhood onset malignancy is uncommon and outcomes are generally quite favorable. What do the experts say for non-syndromic familial non-medullary, this should be non-medullary thyroid carcinoma? Well, this is from Dr. Bauer, who's on the line. And to quote him, I hope he still agrees with it, the data support that annual clinical surveillance with physical exam and or ultrasound is reasonable. So this doesn't mean necessarily an ultrasound every year. And another group, Dr. Kebabu, who's now in San Francisco, did feel that those who have familial disease, so this is only inherited, 3 or more relatives should be screened with thyroid ultrasound. So the take-home messages, and then we'll open it up to questions. Most thyroid cancers, 95% is not inherited, but be on the lookout for 3 or more affected first-degree relatives, association with syndromic features as I described, medullary thyroid carcinoma, which is associated with MEN, and we can offer primary prevention for those of highest risk and high risk, and secondary prevention for those with moderate risk. For those with possible familial PTC, surveillance is a very personal decision based on their perceived benefits and risks. So with that, I'd like to thank the ThyCa group again. I'd like to thank Dr. Franco for her talk, and particularly to the patients that are treated in my clinic who inspire me every day, and who make this really worthwhile and gratifying for me. So I'll open the floor to questions.
So I know we only have about 1 minute left, but we have one question. So
Okay.
maybe that'll do it. Please comment on the value of genetic testing when 3 or more adult family members have had papillary thyroid cancer, especially for monitoring thyroid cancer risk in children of an affected family member.
So it's a very good question. I think 3 or more adult family members, it depends how close they are to the child. If they're grandparents, aunts, and uncles versus parents and siblings is a little bit different. In the absence of a syndromic diagnosis, so Dicer 1, P10, Cowden syndrome, Carney's complex, there's no single gene, there's no panel of gene tests that are really able to offer every family seems to be different. And so there are no gene tests to offer. So the question for those individuals is they may want to consider surveillance exams or ultrasounds, but I wouldn't suggest at this point any gene testing. Some of the companies do offer gene panel testing, but those are really related to the genes that underlie those syndromes. So if someone has done a really good history and examination and did not raise concern for the syndromes, then I would not advocate any genetic testing at this point. There are plenty of research studies that are looking to identify that, but clinically those aren't available yet.
And I think that's all we'll have time for, unfortunately. So thank you so much.
Alicia said we can go 3 to 4 minutes, but not longer.
Can we?
Over, so,
Okay, did she? Okay. Well, there you go. Okay, we have 2 more questions. Should we try to get through them quick?
Sure.
My father, myself, and my daughter all have had PTC. My father is in his 60s, me in my 50s, and my daughter in her 30s. Does this sound like a genetic case?
So I think that's similar to the question that we just addressed, is really it depends on other diagnoses in the family. I'm not sure that there's a lot of genetic testing at this point in time that I would advocate in the absence of other conditions, other medical diagnoses. Certainly reasonable to meet with a geneticist or a genetic counselor who has expertise in cancer genetics, if there is one in your city. Otherwise, you may want to think about surveillance visits to the doctor for your family members without genetic testing at this point. I don't know, Dr. Franco, do you have any thoughts about?
So the only thing I would add is that I think, you know, this is why we spent so much time talking about the difference between your germline versus those heritable and non-inheritable. And there's a danger of the fact that we still don't know a lot. And even if we find something, and I love using the term variant, not mutation, is we all have tons of different variants and many of them that we don't have any idea what they do. So just because we find it doesn't mean we're going to have an answer. So I think it's critical, and that's why I do what I do in the research space, is to try to figure this out. But there's a real danger with digging sometimes because we find answers that don't give us answers or don't give us clarity. So we have to keep working and keep looking. But sometimes we just don't know what those different variants mean because we're all different. So.
Yeah, and I agree with that. Many of you may have heard of things called whole genome or whole exome sequencing, which are being offered quite widely, sometimes without the involvement of a genetics doctor to help interpret it. And sometimes you may be finding things and you don't know what to do with them. We find these variants that we don't know what they mean, and they can cause more stress and anxiety when we don't have something to do about it.
Yeah. Sounds good. Thank you both so much.
Thanks again, everyone.
I learned a lot. Thank you also for everything you do for ThyCa and for us as patients. We greatly appreciate it. Have a good day, everybody.
Bye, everyone.